Hello, everyone. Welcome, welcome. We have so many questions today that we are not going to wait too long for people to join. We're going to get right on it. So first, we'll introduce ourselves. So I'm Grace Veraceli. I am the lead menopause coach here at Elektra. My background is in women's health as far as perinatal first, and now newly board certified health and wellness coach. And I've been with Electra for 4 years, and here is Nora Lansen, who will introduce herself.
Thanks, Grace. Yeah, I am Nora. I am a family physician and Menopause Society certified practitioner, and I am the Chief Medical Officer at Elektra.
Awesome. Before we dive into the questions, we'd love to understand what brought you here today. So we're going to launch a poll so that you guys can answer what brings you here. Does everybody see the poll there? And once we get enough, we will answer. Awesome. Thank you. And we'll see what the answers are. So we'll give you guys 30 more seconds to answer. If you're just joining, please answer the poll questions. So we'll end the poll now. Okay, so 48%, pretty even split, perimenopause and postmenopause. 4% not sure. The majority of them know the basics. Some people know a lot, and a couple of people, the 9%, completely new to me. So, welcome again, and we will get to your questions now. I believe somebody was saying there's a weird echo sound. Is anybody else hearing this? Um, we are not. It seems to be okay. Okay, so moving on. Um, okay, let's start with the first questions. So we got a ton of questions, and we are probably not going to get to all of them today, but we compiled some of them, and we'll get through as many as we can. There's more to come. This is the first of these sessions that we're doing about hormone therapy. So bear with us if your question is not answered. We will try to get to them as much as possible. So, first question, what can hormone therapy help with, Nora? What is hormone therapy for?
It's a great question. And if anyone else is hearing an echo when I speak specifically, let us know and we'll try to fix that. But yeah, and Grace, just quickly to echo what you're saying, the questions that everybody sent were just extraordinary. Thank you so much for your interest in this topic, and really the caliber of the questions was amazing. And I can't wait to discuss all of this more, but we'll get to as much as we can in our brief time today. So hormone therapy helps with a lot, and also we don't exactly know. So there is a term that we use with some frequency called evidence-based information, and that means what the research shows and what the data shows and what is explored via scientific inquiry. And those bits of information are ones that we feel very confident about, and really point towards a reliable, reproducible effect from any particular medicine. And then there is information that is what we call anecdotal, like it sounds, based on anecdotes. So as a menopause clinician and Grace as a menopause coach, we hear things from our patients, and those are anecdotes. But as we hear more and more of the same things, we kind of feel like that tells a story, and to us, anecdotal evidence is important when it stacks up against evidence-based research-oriented information. There's some nuances, but both are important. So From an evidence-based perspective, we know that hormone therapy helps to prevent osteoporosis, and we know that it helps with vasomotor symptoms, so hot flashes and night sweats. And that's it. That's as much as the evidence shows. Anecdotally, and I'm sure Gracie would agree, we hear that it helps with all sorts of things. So we know that there are over 35 symptoms of perimenopause and menopause. And so we, in practice, find that many people find hormone therapy helpful with mood changes and erratic bleeding and joint pain and insomnia, and the list goes on and on and on. In the anecdotal space, one thing to note is that what works for one person doesn't work for everyone. So even though you may hear in your social media feed that absolutely you have to start menopause hormone therapy like yesterday in order to treat all of your symptoms of perimenopause and menopause and prevent all of these things, we just don't know that. And in fact, anecdotally, the patients that I have, some do well with hormone therapy for joint pain and some don't. And some do well with hormone therapy for insomnia and some don't. So it's a little bit unpredictable, but hopefully that answers the question sufficiently. And I will just pause to say, or I'll add on perimenopause, just so we're all on the same page and in case someone's not sure of the definition. Perimenopause, that is the phase of years prior to the final menstrual period. Menopause is the final menstrual period and 12 months after that period with no bleeding. And so it's sort of a retroactive designation. You only know that you've been through menopause after it's over, and then you're postmenopausal.
Right, right. And the other thing about it is that it's so individualized. Like everybody, we know that there's like a host of symptoms, but not everyone has all of the same symptoms. So it's what works for one person could work for another or not work for another. Some people go through it without anything just fine. Some people are having a hard time. So just keep in mind that these are all nuanced answers. There's more nuanced answers to what we're saying today. And by the way, if you have questions that are not addressed, or like if there's something that comes up, please put it in the chat and we will try to get to it as well. Moving on to the next question. Um, is it ever too late to start hormone therapy? And I'll add to that, should you stop at a certain point? So like the timing question.
Yeah, it's a great, great question. So the short answer is yes, it can be too late to start menopause hormone therapy. I will frame that by saying every individual, whether you're in perimenopause, in the thick of menopause, and postmenopause, should be consulting with a clinician. And these answers that I provide are general, but really we believe in patient-centered, individualized care. And that means what works for the general population may not work for you or may not apply for you. But from a general perspective, yes, it can be too late to start menopause hormone therapy. So generally, we recommend starting prior to age 60 and or less than 10 years after your final period. The reason is there's an increased incidence of cardiovascular, negative cardiovascular outcomes like stroke or heart attack if you start far away from your final period. Some people may know about the Women's Health Initiative study. That was a gigantic study in the late 90s, early 2000s. And at that time, the data showed what we interpreted as a very high risk of adverse cardiac outcome from hormone therapy in general. And that's why hormone therapy was not prescribed for 20, 30 years. In that time, we've reevaluated the data and found that actually timing really matters. So this is called the timing hypothesis. And the hypothesis is that we all age, obviously, and our vasculature ages. So our coronary arteries, the blood vessels that go to the heart, they age, and over time they become stiff, and also over time they can build up plaque, usually from high cholesterol. This can happen, it happens pretty much to all of us. Vascular aging is part of the aging process. If we start hormone therapy before that process starts, the thought is that we are helping to prevent plaque from building up. We're helping to prevent stiffening of the arteries. If we wait until later in life, that process may have already started, and then hormone therapy can mobilize a plaque that may be sitting in the arteries and cause a heart attack or a stroke. And so the risk is higher of something bad happening as you age. In the 60s, the risk is still what some may consider relatively low. Less than 5% is what we think at the moment. Over 70, it's higher. So again, that needs to be an individualized decision, but in general, we recommend starting before 60.
Awesome. And is there a time where you should stop?
Oh, right. Thanks for that. So the official guidance is if you find that hormone therapy is so helpful for your symptoms, if you're someone who tries to stop after a few years and your incapacitating hot flashes come back, then again, based on a discussion with your clinician, you can stay on it for as long as you want. And there is no recommended time to stop. That said, we are still learning because we are catching up after all of those years of not having prescribed hormone therapy. So as we learn more, those guidelines may change. I think it's safe to say that at the moment, there's no hard stop. You want to try to use it for as long as you need it and then taper off. But there is not a hard stop recommendation.
So thank you for that. On the same vein, there was a question about hormone therapy safety. So, and one of the questions was about can it cause cancer?
Great question. So, again, based on the Women's Health Initiative, we thought for a long time that it was really unsafe, that any type of hormone therapy was unsafe. What we now know is that there are certain things, in addition to the timing hypothesis, the type of hormone therapy that you use matters. So, the type of hormone therapy that was studied in the Women's Health Initiative was an oral combination of a particular type of estrogen and a progestogen. And the types of medicines that were studied tend to have, it's the estrogen component in particular that tends to have a higher risk of blood clot. More commonly now, we start with transdermal estradiol, and that means estrogen that is absorbed through your skin. What our current research is showing is that there is no risk of blood clot when using this type of estradiol. So, without getting too in the weeds here, it bypasses metabolism by the liver and thereby mitigates the risk of blood clotting. So, the type of hormone therapy that is most commonly in use now is quite safe from that perspective. It depends on your individual risk factors and a personal history of breast cancer does make a difference. So, for someone who has had breast cancer in the past, we still feel a lot less comfortable prescribing hormone therapy because if someone has had an estrogen receptor breast cancer in the past, adding more estrogen to the mix is obviously not a good idea. And then we have a question mark about the type of endometrial protection that we use. So for anybody who has a uterus, you have to, in addition to estrogen, use something to protect the lining of the uterus. Estrogen can thicken the lining of the uterus, which can lead to uterine cancer. So we want to keep it thin and healthy. And the most popular first line menopause therapy combo right now is a transdermal estradiol and oral micronized progesterone. And we think that that oral micronized progesterone has a very low, possibly zero risk of breast cancer. We are still learning, so I don't think that anybody right now is comfortable enough to say 0% risk. We know that the progesterone has some activity in the breast tissue, but at our current level of research, we do not think that there is a substantially increased risk of de novo breast cancer, meaning we don't think hormone therapy causes breast cancer in the average person.
Right. Awesome. Thank you for that. And now the next question is, how does someone know that they're on the right dose? How do you know if it's too high, too low, or if you're just right?
Yeah, the nice thing about this is it's symptom based. So, as we've been discussing, it's such an individual journey. And as you rightly said, Grace, not everybody has the same symptoms, constellation of symptoms, or severity of symptoms. And so we dose hormone therapy according to symptom control. So if we find that you are at a dose, at a low dose, I've had many patients, we started an ultra low dose of hormone therapy and everything feels better. And
Yeah.
that's the right dose for them. And it can change over time. You may need to increase, or sometimes we go too high and someone will have side effects like breast swelling and tenderness is one that I frequently encounter with my patients where if the estrogen dose is just a little too high, they get really uncomfortable. So we go back down. And so it is some trial and error. But the nice part is it's not like a lifelong commitment. You can change, you can adjust. And so it's really guided by your own body and being aware of how your symptoms are improving over time and, just staying mindful and adjusting as necessary.
Right. So on the same vein, the question was, should you or do you need to get labs in order to get hormone therapy? Is it
And
based on your labs at all?
right. No, the appropriate dose of hormone therapy is not based on labs. It would be fantastic if we had the capability of diagnosing and treating to lab results. I would love that. That would take a lot of effort off my plate, but it's not, we by current lab testing, we just don't have that capability. And it's a confusing topic because it seems like we should like, oh, we can check my estrogen, we can check my progesterone, but the level that returns is not reflective of your body's own estrogen production, depending on where you are. So if you've got an estrogen patch on and you're testing, then you're picking up on some of your body's estrogen and some of the patch, and it doesn't correlate with symptoms. So again, this is a symptoms based methodology, and what one person feels at a certain estrogen level is not going to be the same as what another person feels at a certain estrogen level. And then to further complicate matters is perimenopause. After menopause, your estrogen is low, negligible, and it stays there. Before menopause, particularly in the final couple of years before your last period, things are so wonky. They're all over the place. And what your levels show one day are going to be almost very predictably different than what they show the next day. Your estrogen is going up and down and sideways, and that's what's causing the symptoms. And so testing is not helpful. And in fact, it's sometimes counterproductive because if I'm someone struggling with, 20 symptoms of perimenopause and I go to my doctor and I get labs and the lab results return and my level is normal and my doctor tells me, "Oh, you're fine." That feels really invalidating. And I don't want to have to prove that I'm struggling. And I know that in our culture, we like to look at, I've been talking about evidence and information and data and looking at something on the page and saying, there, I can prove it. And in this case, that just doesn't apply. And we don't want people to feel worse when we're already struggling.
Yeah, for sure. That was one of the things I was going to mention. Like how many of us have gone to our gynecologist in early perimenopause or mid perimenopause, and they're like, "Oh, your levels are fine," and it's like, "But I don't feel fine," and it's all about the symptoms and how you feel. Um, Questions about testosterone. We got a lot of questions. Can testosterone help with menopause symptoms? Is one of them.
Yeah, testosterone is a very hot topic, and we could talk about it for probably a full hour or more. Um, uh, and I think there is, social media is great in some ways, in that it's really generated so much information about the topic of menopause when, again, there was like a desert and a dearth of information for, at least a generation. But it can be hard to explain nuance on social in, like a 30-second reel. The nuance of testosterone is that, yes, it can be helpful for some symptoms of menopause. Right now, we know that it helps with libido. So if you are someone who has been doing well with the menopause hormone therapy regimen of usually estrogen and progesterone, but your sex drive is absent and it is not improving, then testosterone can be helpful. We do test testosterone levels and just want to put a fine point on this because that can be confusing too. Well, I heard her say we don't need to test levels. Usually we start with a baseline testosterone level just to make sure that you don't already have enough in your system that if we were to add more testosterone to the mix, it wouldn't be a good idea. That could cause masculinizing side effects. Um, but we are not checking a testosterone level to see if you're too low because we don't even know what too low is for a woman. And again, that doesn't correlate with symptoms, at least not right now with our the current lab testing available. It does not correlate with like how low our sex drive is. What many people have likely seen is testosterone's great for weight loss and focus and energy. And we do not have the evidence to support that right now. So that's not how I would recommend using it.
Okay. Seems like a lot of it is just lack of research at this point,
Yes,
and which
that's
we know is like it's a
yeah.
problem with women's health. Okay, so we're gonna go to some of the questions that are in the chat right now. You mentioned about hormone therapy helping prevent osteoporosis, but what if you already have osteoporosis? Like, what does it do for that?
Yeah, it's not a treatment for osteoporosis, unfortunately. It does help to prevent the loss of bone density, but it doesn't necessarily help to restore it. Now, anecdotally, I have had patients or read cases where someone does a DEXA scan and then they do some hormone therapy and strength training, and their DEXA, that's the bone density test, improves over time, but it's not borne out yet in the research. So if you have a diagnosis of osteoporosis that really needs to be treated with osteoporosis medicines, you can still use estrogen, but not as a primary treatment.
Right. And so we had also some questions about types of hormone therapy. So question number one, can low estrogen taken continuously for endometriosis while in perimenopause be considered beneficial for perimenopause symptoms, or are the hormone levels too low?
Great question. So, in fact, the pill, like Loloestrin and all of the brands of the pill can be not only beneficial in perimenopause, but for some people more advantageous than menopause hormone therapy. And again, it's a little complicated, a little nuanced, and very individual, but when you're in perimenopause, as I was mentioning before, your estrogen levels are all over the place, and so are other hormones. And the amount of hormone, again, it's estrogen and a progestogen, a synthetic progesterone, progestin in the pill, in the birth control pill, those doses are higher than what is in menopause hormone therapy. And for many people in perimenopause, particularly late perimenopause, the low doses of menopause hormone therapy are not enough to manage the symptoms of wildly fluctuating hormones. And it's actually the pill with higher doses of estrogen and progesterone that helps to maintain a steady state so that your own hormonal fluctuation is bumping against the ceiling and not, it's not as dramatic and destabilizing. Menopause hormone therapy, which is more like down here, you're still going to be going way over it. So most people who don't have relief of menopause symptoms or perimenopause symptoms with menopause hormone therapy find they do much better with the pill. The pill is a great place to even start as a first line consideration if you're in perimenopause. So yes, great question. And yeah, I'm a big advocate for the pill and peri.
What does research say about transdermal estrogen and an IUD that releases progesterone?
Research says that the Mirena IUD, so the IUD that can stay in place, the way that when you have an IUD insertion, it's usually communicated is that it's effective for birth control for up to 8 years. The research says that it's effective for endometrial protection and menopause hormone therapy for 5 years. So more research to come. Could it last longer? Probably. Actually, the IUD, when we first started using it, it had a short, I think it started with 5 years actually.
Yeah.
And then it was like, oh no, it's good for 6, 7. Now it's up to 8. And so we may find that over time with menopause hormone therapy. But for now, it is a great version of endometrial protection. You can use transdermal estradiol and keep your IUD in place for up to 5 years.
And it can help with in perimenopause with bleeding. right?
Crazy bleeding, definitely, and also pregnancy prevention, if
Right.
that is, something to consider in perimenopause, especially when periods are so unpredictable. Pregnancy is definitely a consideration, and pregnancy prevention with the IUD is like, super convenient.
Yeah, sure. So you're hitting two things at once. So question about stopping HRT. If you want to stop taking HRT, should you titrate down or can you stop taking it abruptly?
From a physiologic perspective, if you stop abruptly, especially if you're at the higher range of the dosing window, um, your symptoms may come back, and that might not be your baseline. That might be a little bit of a rebound. But from a safety perspective, you can just stop. It's nothing bad is going to happen to you if you stop, and nothing bad is going to happen if you skip doses. You, if you're in perimenopause, may have unpredicted bleeding, or you may have a resurgence of symptoms if you skip, or like you just realize your patch has fallen off or whatever, but it's not dangerous. Nothing fatal or otherwise is going to happen to you if you abruptly stop. But for someone who's been on menopause hormone therapy for, let's say, 5 years, particularly if they've been at the maximum dose, it is gentler to your system and reduces the risk of rebound symptoms if you taper.
Right. And it might be something that you kind of want to get off, but you don't know like at
Yeah.
what point the symptoms are going to come back. And then if you go low and you have symptoms again, then you can say like, oh, maybe I shouldn't go off at this point. Maybe it's time to still stay on it. Question about estrogen and does it have any impact on inflammation that is seen with most autoimmune disorders?
We think that estrogen has anti-inflammatory properties, and there is a little bit of research to support this idea, but it is not fully evidence-based yet. And thereby, you may see some benefit with some things like joint pain, for instance. We think that estrogen probably lubricates joints and has this anti-inflammatory action that helps to prevent swelling and pain, and that may be the mechanism by which joint pain is alleviated by estrogen. With full-blown autoimmune diseases, I would say that estrogen's not really a reliable treatment. If someone feels better, who has rheumatoid arthritis, let's say, that wouldn't be a total surprise. But right now, by the evidence, we're not saying that menopause hormone therapy is a, appropriate treatment for autoimmune diseases.
Yeah, and that's a great question to ask your clinician. So just want to point out, like Elektra, we take all kinds of insurance. There are a lot of clinicians that are available to answer your particular questions, because something like this is like it's so nuanced, like a lot of the questions that we have here, and we want to make sure that you get the right information for you. So, we welcome you. Question about what does it mean if you've been on HRT for a couple of years, but in the past year have started to randomly bleed for a few days here and there with bleeding and duration increasing each time? Should you stop HRT? I think this question, if this person could answer if they are perimenopausal or postmenopausal would be helpful, but do you think you can answer so
Yeah,
far? Yeah.
yes, that makes all the difference. If you're postmenopausal, so again, you haven't had a period for more than a year, and you are using menopause hormone therapy, if you just randomly start bleeding, that absolutely requires an in-person evaluation and usually an endometrial biopsy to rule out uterine cancer, because uterine cancer, the vast majority of the time, like 90% of the time, the presenting cardinal symptom is uterine bleeding. So you want to make sure to not miss that diagnosis. And it's a very treatable cancer. So getting diagnosed early is important. If you are postmenopausal and you've just started hormone therapy or just adjusted the dose and you're having a little bit of spotting, we sometimes allow for that without rushing straight to an endometrial biopsy. We can sometimes do an ultrasound first to see how the lining of your uterus looks, but that really should be discussed with a clinician and not managed on your own. If you're perimenopausal and you haven't had a period for 6 months and you start hormone therapy and you have a period, not totally unexpected or alarming. Again, hormones are all over the place during perimenopause, and that can happen.
Yeah, sure. Again, a question that's really good to have a discussion with your clinician because some people might have started a GLP-1, had been in like perimenopause, hadn't had a period for a while, and then all of a sudden started having periods again because we know that there's some correlation between that. So again, we want to make sure that you guys don't take these questions as blanket statements. These are all very individualized. We're just giving kind of like an overall answer. So a lot of questions, we got a lot of questions, and there's a question here about weight, perimenopausal weight. Can the estrogen patch help or worsen weight gain taking place during menopause? Mainly my question is it responsible for weight gain as a side effect?
No, is the shortest answer, but it is totally individual. I have had some patients who it's usually not the estrogen component, it's often the progesterone component that people feel. Um, uh, Generally, they may see some increase on the scale, usually from water retention. People feel more bloated, more puffy. That is a rare side effect. It's not zero. And again, that's very anecdotal. This is a disappointing answer overall, but of all of the symptoms of perimenopause and menopause that menopause hormone therapy helps with, I would say weight is the one that it really does not generally ameliorate. So some people do lose weight spontaneously when starting menopause hormone therapy, maybe a couple of pounds. For most people, menopause hormone therapy can help with energy levels and with sleep. And so, if you're sleeping better and you are not as tired and you're not reaching for coffee or sugar because you're feeling tired, so your nutrition is getting better. And so, sort of like from a global perspective, things are getting better, then your workouts are going to be more productive. And people do find that overall excess weight comes off. But it is not an anticipated result of menopause hormone therapy.
It's not automatic for sure.
Yeah.
Quick question around that. Vaginal estrogen, can it cause bloating, weight gain, or increased appetite?
No, vaginal estrogen is just absorbed locally, so into the vaginal tissue or the skin where you apply it primarily. And vaginal estrogen does not have systemic effects. So, since the whole body is not processing it, you wouldn't expect to have any improvement or side effects in more general symptoms.
Is there any anecdotal data around HRT and prevention of cognitive decline?
That's a great question. I was thinking about that before we started, actually, as a good example of what seems like it might be true, what we would love to be true, what many celebrity Instagram doctors are telling us is true, but we do not know that it is. There is a lot of data, a lot of research happening right now on this topic, and Pauline Mackey is one of the lead investigators, and I would say she has the most published data around this. So if it's of particular interest, you can read more. Uh, there have been studies lately specifically on this question, and the results have not shown what we thought we might uncover, which is that estrogen is good for the prevention of dementia. We're actually not seeing that. We are seeing that it may help with people who have strong vasomotor symptoms, so like terrible hot flashes and dementia. For those people, it seems like maybe there is some benefit. But then the question is, okay, well, is it actually the vasomotor symptoms that's signaling some sort of predilection for dementia? And that's what the estrogen is helping with. And that's why evidence is important, because it helps to answer those questions. If you're taking away something from anecdotal research, you can easily misapply the information that you have to mean something that it doesn't actually mean. So more to come on that in the future, and we may, come up with a protocol for the prevention or treatment of neurocognitive decline, but right now, no.
Have a really good question that somebody had sent in. Then we'll get back to the ones that are on the Q&A. But how long should I give a new dose of HRT a chance before adjusting? If a new dose makes me feel worse, would blood I think we answered about the blood test helping or not. We don't think so. It's more about the symptoms, but how long should you give before you decide that the dosage is not okay?
Yeah, the party line is 3 months. So the official guidance is allow 3 months for your body to adjust to any new hormone regimen or any adjustment in your hormone therapy dose. That feels like a really long time to some people. And again, this is why it's great to have a relationship with a clinician or menopause expert so that you can ask along the way. I, in my own practice, often will meet with someone after about 2 months just to see how it's going. Because usually, especially if we're starting out, if it's been 2 months and there's no improvement whatsoever, I feel like, that last month, I'm not sure that suddenly it's going to kick in.
Right.
But if there's a little bit of improvement, then we'll talk about it. As far as side effects go, if you have a tolerable side effect, so if you've got some breast swelling and tenderness, but it's manageable and it's a week or, maybe 2 weeks, that's fine. If you have like a mild intermittent headache, that's okay. Try to push through that. But again, you can discuss with your clinician. If you suddenly have a migraine and you've never had a migraine before, no, we do not want to tolerate a new significant side effect. This is particularly true with mood symptoms.
Mhm.
So some people, especially those who have a history of hormonally mediated depression or anxiety, like someone with a history of PMDD or postpartum depression, or just unrelated to hormones, generalized anxiety disorder, sometimes those symptoms can get way worse in perimenopause and menopause. And sometimes hormone therapy helps. And for some people, it's the opposite. For some people, hormone therapy can make us feel way more anxious or more depressed. And that is also a side effect or treatment outcome that I wouldn't tolerate. Like, do not push through your terrible depression for a week. Discuss with your clinician.
Awesome. So we're getting kind of close to time. We have 3 more minutes. So one more question, and then we just want to let you know that we are keeping your questions and we're going to try to do this again at some point. We want to encourage you to see a clinician to answer your particular questions as well. But we are, so many questions came in. We're so happy to be able to answer them for you. We just don't have the time to hit all of them. But a really good question is like, what options does someone have who is in postmenopause? Like, is it too late for us? What can you do?
Yeah, in as much as I love that menopause is a topic being discussed all over now, I do think there is this risk of people feeling left out, right? Like, oh my God, I missed my window, and now what? And that's just not the case. If you have already been through menopause and you're in your late 60s or 70s, it's okay. There have been multiple people who have not used hormone therapy and been okay. And there are still many, many people who are not eligible for hormone therapy, and they're okay too. You haven't missed out. And I would say, if you are someone for whom it's too late by, what we were talking about earlier in terms of risk of cardiovascular issues, or you're someone who can't use hormone therapy because you do have a personal history of breast cancer or a blood clot. For those people, there are other medication options. And if you're someone there are definitely people whose last menstrual period was more than 10 years ago, but they're still having hot flashes. If it's not advisable to start hormone therapy, there are other medicines. And that's true for everyone, regardless of age. Hormone therapy is not the only treatment option. There are other classes of medicines, and there are non-medical interventions. And Grace, as a coach, you know all about those, ranging from cognitive behavioral therapy to acupuncture. There is so much to do. And also, I think something that's often overlooked is there are some variables that we can't exactly control for, as I was mentioning earlier, like sleep is a huge one. If
Yeah.
you are able to get more restorative sleep every night, that absolutely impacts your health and even menopause symptoms. And so it's not just about the hormone therapy. That's
Yeah.
not.
Sleep is definitely the first thing that we talk about in coaching, because everything it's the foundation of like your health overall. If you can't sleep, your brain doesn't get clean, your body just doesn't work the same. You just don't have as much energy, you get a lot more brain fog, et cetera, et cetera. So getting your sleep to a good point as much as you can is super important.
Yeah.
We want to thank everyone. Sorry, were you going to say
I was
something?
going to say, and that also is borne out in the research and the evidence, not just anecdotally, is time and again what the studies are showing, even when we're not looking to see if sleep is so important, it comes up as something that is a major contributing factor to health. All right.
All right. Thank you all so much for coming. We unfortunately couldn't get to all of the questions, but there's more to come. Please keep an eye open for an email with the event recordings, the event recording today, and more information about all of these questions. Like I said, there will also be a link so that you can make an appointment with a clinician, so you can get your particular questions answered as much as possible. We just wanted to let you know we're here for you, and we hope you enjoyed this. Thank you so much and have a great rest of your day.